these sessions. Okay, you have these sort of diagnostic long cases where arriving at a differential diagnosis is the main focus of the case. And then you also have these cases where management issues are the priority of the case, like, for example, diabetes, hypertension, right? Now, we'll start off with most of these sort of diagnosis-based long cases where you're expected to come out with a differential diagnosis after your assessment. And we'll start off this today. And for the next, say, four weeks, Vitara, we will be focusing on this. 3 to 4 weeks, we'll be focusing on long cases only. Hari. Now, when we are doing these classes, the first thing that you have to do is you have to listen to the person who's presenting very carefully, and all of you individually have to write down a summary, right? Individually write down a summary, and also we'll listen to the summary that the presenting person is presenting as well. But all of you need to write it down, and you need to have a special sort of a place where you write these down. Why it's so important is these are the things that you're going to do just before going to the exam. You're going to go through all the long cases that we have discussed during the appointment. And I can guarantee that if you do that, you're going to do very well at the exam, because these are the cases that you will get, right? Obviously not the same patient, but very similar sort of clinical problems. Right, David. Okay, start.
So can you hear me, sir?
Yes, I can. Yes.
Mr. Kittasamy, a 62-year-old chef from Hatton and a father of 2, presented with fever for 2 weeks duration. He was apparently well 2 weeks ago when on the 20th of March, he developed a gradual onset, subjectively low-grade fever, which was intermittent in nature. He had noticed once daily fever spikes during that period. The fever spikes were more pronounced in the evenings, with its onset usually being from about 9 p.m. onwards. However, he had not measured the temperature of the fever spikes. The fever spikes were associated with chills but no rigors, and it responds to simple antipyretics. He was relatively well during fever-free periods. With the onset of fever, he also complained of night sweats, loss of appetite, and a generalized body weakness. 1 week following the onset of fever, on the 31st of March, he developed a productive cough, producing scanty whitish sputum, but there was no blood in the sputum, any associated shortness of breath, or preceding upper respiratory tract symptoms. And he has no close contact history of TB. He has not had any recent hospital admissions prior to the onset of fever. He is not a known patient on any immunosuppressive medications. He does not give a significant travel history, nor has the patient been a recipient of any transplant organs. He did not have joint pain, hair loss, skin rashes, or a history of heat intolerance, loose stools, or loss of weight. He complained of easy fatigability, but did not have any easy bruising, other bleeding manifestations, or a history of recurrent infections. He has not had any dental procedures prior to the onset of fever. He has no history of IV drug use or high-risk sexual behavior. There was no history of cardiac problems in childhood. However, he is a known patient with a cardiac valve disease since 1 year ago and is awaiting valve transplant surgery. There is no family history suggestive of connective tissue disorders or malignancy. He sought medical attention from NHSL 2 days after the onset of fever, where he was investigated with blood and urine investigations, an ECG, and a 2D echo. He was treated with oral and IV medications and discharged in 2 days. However, the fever persisted, and thus he got readmitted on the next day. During his hospital stay, he was diagnosed with COVID-19 and was transferred to the COVID ward, where he was managed for 6 days and then transferred to the medical ward for further management. Since then, he has been investigated with further blood, sputum, urine investigations, and a repeat transthoracic echocardiogram, a chest X-ray, and MANTU were done. Patient is not aware of the results. The patient currently does not have fever, but complains of loss of appetite and is awaiting to undergo a transesophageal echocardiogram. Regarding the patient's past medical history, he is a known patient with diabetes mellitus and was diagnosed 1 year ago when he presented to the hospital with a cerebrovascular event. He complained of the presence of osmotic symptoms at the time. However, he cannot recall his initial investigation results. He was asked to follow up at the NHSL clinic. However, he had defaulted follow-up and treatment as he could not visit the clinic due to his disability following the stroke. Thus, he has not been on any oral hypoglycemic agents or insulin. Regarding the complications of diabetes mellitus, he has had ischemic heart disease in 2019 and underwent stenting, and also had a history of stroke as mentioned before last year, which was following which he developed right-sided upper limb and lower limb weakness. He also complains of having frothy urine for the past 1 year and reduced sensation of the right foot. He has not been screened for retinopathy and, however, does not complain of any reduced vision in either eye. He's also a diagnosed patient with hypertension for 3 years. He was diagnosed during a routine medical checkup and is on medications. However, he cannot recall the names of the medications. He has no significant past surgical history or allergic history. He has a family history of diabetes mellitus and hypertension, but no other significant family history. Regarding his social history, he works as a chef in a bungalow in Baudaloga, Mawata and earns about 30,000 rupees a month. He supports himself and his wife financially. His wife is a housewife living in Hatton and he visits Hatton only once in 6 months. He can perform his activities of daily living and instrumental of activities of daily living independently currently. He lives in the house that he works in Colombo and NHSL is about 20 minutes away by three-wheeler. He has been educated up to grade 5. He's not an alcohol consumer and he does not smoke and is not exposed to any passive smoking as well. He does not use any other illicit substances. He's not aware of what he has currently. However, he is concerned about whether his current condition will affect his heart and his past stenting procedure. And he wants to get better soon and return back to work.
Okay, Naveen. Before we go on to the examination, can you just summarize the history for me?
This 62-year-old male from Hatton presented with a low-grade intermittent fever for 2 weeks duration, which is more pronounced in the evenings and is associated with chills, night sweats, loss of appetite, and generalized body weakness. He also complains of a productive cough for 1 week with no associated exertional dyspnea. He had no significant travel history, close contact history of TB, childhood cardiac problems, IV drug use, or high-risk sexual behavior. He is a known patient with a cardiac valve disease since 1 year ago and is awaiting valve replacement surgery. And is a patient with hypertension and diabetes mellitus complicated with ischemic heart disease, stroke, and symptoms suggestive of nephropathy and neuropathy.
Okay, right. So thank you for that very nice history presentation. The only thing I would, and the summary is also good for start. You're just starting, remember, and you've got a long way to go when we come to sort of case presentation, but that's a very good start. The only thing I would change is, now this guy, you have a sort of, you're working towards a diagnosis of endocarditis. No? That's what you're implying, and the history sort of pointing towards it. There is no point in hiding the fact that this guy has a cardiac valve problem. No. So in your summary, I would advise you just say that right out, right at the start or top. Right? So there's no point in hiding the fact that this guy has some cardiac valve problem. So you can say that after you present in his past medical history, this guy has some cardiac valve issue before you talk about the other things. Okay? Before you talk about the negatives, talk about the obvious positive things first. So I just restructure the summary a little bit and then you should be fine. Yeah?
Yes. Okay.
Okay, right. Hari, now I think all of you would have appreciated this history and the summary. So let's talk about this a little bit and then go on to the examination. Right. Now, the class today is on prolonged fever. Okay. Prolonged fever without an apparent focus. Okay. Prolonged fever without an apparent focus. That is a class. Now, this theme, prolonged fever without a focus, and the word pyrexia of unknown origin, the statement pyrexia of unknown origin is slightly different. Okay. So let me first explain what the definition of pyrexia of unknown origin is, and then I'll teach you how to assess a patient with prolonged fever and without a focus. But pyrexia, on the term pyrexia of unknown origin, the definition is slightly different from prolonged fever. That is what I need to tell you. Right? So they are not the same things, essentially. Right. Pyrexia of unknown origin was initially defined a long time ago, right? And I've shared a nice article with you, so all of you should read after we finish the class, right? And that gives you all sort of historic diagnosis of pyrexia of unknown origin. But when it was initially diagnosed, right, pyrexia of unknown origin, what it meant was the patient presents with fever, which was going on for more than 3 weeks. Okay, patient had fever going on for more than 3 weeks. The fever had to be clearly documented and there was fever going on for 3 weeks. And then the diagnosis or the cause for the fever could not be discovered in 1 week of inpatient investigations. Right? So there was fever for 3 weeks, and then the diagnosis was not established after a week of inpatient investigations. Now, this was a long time ago. This definition of PUO was a long time ago. Now, as you know now, the story is different. And because of advances in investigations, right, blood and imaging investigations, and obviously we have advanced medical knowledge, this definition doesn't hold true anymore, right? This 3-week business, 1 week of hospital admission story doesn't hold true anymore, right? And there have been various amendments proposed to this definition, which I want you to read about. Just refer. Exam mein ahanne what is the definition of PUO kila ahanne hai, but I just want you to read a little bit about the current definitions of PUO. And remember, they are not the same as which was mentioned, I think in 1960s or something, that was initially described, right? So now these time durations are different. Also, there doesn't always need to be 1 week of inpatient investigations or inpatient investigations at all to qualify for a diagnosis of PUO. So I want you to read about the current definitions of PUO. Right. Now, as you can realize, the word PUO and prolonged fever without a focus are different, right? PUO has a very strict diagnosis. And remember, in your long case history and examination, you can't diagnose PUO. Now, it is a common mistake that you make, right? At the exam, you say, oh, this is a patient with PUO. Remember, without investigations, you can't diagnose a PUO, right? So the clinical problem is prolonged fever without an apparent focus, right? Because in order to diagnose PUO, you have to show you do all the investigations, still you can't find a focus. I think exam mein PUO kiyala, you say the patient has prolonged fever without an apparent focus. That is a clinical diagnosis. PUO has a more stricter definition, which involves investigations and other things. Right. So having said that, let's go on. I'm going to teach you now how to approach a patient with prolonged fever without an apparent focus. Prolonged fever without an apparent focus. Right. Okay. The first thing I have to say in your approach is you have to have a very detailed history. Very detailed history. Right? Very detailed history. And at the exam, one of the key things we look at is, have you described the patient's fever properly? Right? Have you described the patient's fever properly? And now we did a nice job of describing the fever, right? So that is one important thing that we look at. Have you described the symptom properly? Have you described the fever properly? Right? Have you described the fever properly? Okay. That is one thing that we do. Then in a patient with prolonged fever, the cause for the prolonged fever depends on the setting in which it occurs. That is the second thing that you need to remember. In a patient with prolonged fever without an apparent focus, the differential diagnosis or the cause depends on the setting in which it occurs. Now, this is slightly similar to what you're used to when it comes to pneumonia, right? In your respiratory module, they would have told you, right? Pneumonia has community acquired, hospital acquired. Similarly, prolonged fever, the setting, or it has a clinical classification. Clinical classification. Right? This can be used for PUO also, but very similarly. Right? So there's a clinical classification. Okay. So in your approach, once you describe the fever and everything, the next thing is to try to generate a differential diagnosis for this fever. For that, the first thing you to do is you do a clinical classification of the causes. Right? In this all the setting in which it occurs. Right? So how do you classify it? Number one, classical causes, or what we call community acquired causes. Community acquired, or we call it classical laws, right? So what that means is the patient is from the community and they get the fever while in the community, right? Number two, hospital based, right? So some people get prolonged fever in hospital. The differential diagnoses are completely different. Okay, that's number two. Number three is that people get prolonged fever when they are immunocompromised. So the patient is a diagnosed patient with some immunodeficiency, right? That might be HIV, that might be neutropenia, it might be drug-induced, right? So they are immunosuppressed, right? So the prolonged fever occurs in a setting of immunosuppression. Okay. So the prolonged fever occurs in a setting of immunosuppression. Immunosuppression can be neutropenia, right? Can be HIV, right? And also can be drug induced, say somebody on steroids, for example, or immunosuppressants, right? So those are the various subcategories. So prolonged fever from the community, prolonged fever in hospital-acquired patients or hospital-acquired settings. Number 3, prolonged fever in immunocompromised individuals, right? Number 4 is prolonged fever in return travelers. So as you know, there is a lot of international travel, which is now just picking up again. And then people have bring in various imported infections, right? Imported infections. So that is fever, prolonged fever in the return travel. And now some people are proposing that prolonged fever in age more than 65 should also be a different category because the differential diagnoses are different, right? Because the differential diagnoses are different, people think that it should belong to a separate category, right? So maybe then come in your approach or describe the fever nicely, and then your approach should be okay. Now you're trying to establish a differential diagnosis as to what is causing the fever. For that, is it a community-acquired thing? Is it a hospital-acquired thing? Is your patient a diagnosed patient with some immunosuppression, right? Might be HIV, might be neutropenia, might be drug-induced, whatever it is that the setting? It occurs it. Does your patient have a recent history of travel internationally or locally? And is that related to the presentation? And then also with age also, there might be some merit in classifying a different age group at more than 65. Right. Okay, so that is your next thing. Why do we use this clinical classification? Because we know that the differential diagnosis for prolonged fever in each of these categories is different, right? Each of these categories is different. In a known patient with immunosuppressive illness, the differential diagnosis is completely different from, say, a community-acquired person, right? A person who has come from Africa, prolonged fever in a person who has come from Africa, the differential diagnosis are completely different from a person who is in the community in Sri Lanka, right? So this is the sort of outline of your first assessment. Right. Now, looking back at the 62-year-old patient from Hatton, he has diabetes in the past, but there is no sort of significant immunosuppression or whatever. So this is a patient who has had a prolonged fever while in the community, so developed it from the community. Right. Now, in your exam, purely for exam purposes, also you will get this sort of patient. Right? We won't give you any of the other categories, right? Of course, travel history gun or hemogema, so it might be a travel-related thing. But of course, we won't give you these complicated hospital-acquired ones or patients with diagnosed HIV who come with prolonged fever. We will be. This is the sort of case that you will get. Right. Now the next step is, so there are steps to not make it. First you describe the fever, then you categorize it clinically into a clinical group as we have described. And this is for prolonged fever without an apparent focus. You can use the same groups for PUO also, right? Same groups can be used for PUO also, right? But remember, those two things mean two slightly different things. All right. All right. Number three. Right. Now, once you have figured out what clinical group or what setting the prolonged fever occurs in, your next step now is to expand on this, right? Now, the causes of prolonged fever in each of these groups can be further divided into 4 categories. Right? There are a clinical category, and then the causes are further divided into 4 categories. Right? One of the 4 categories. Number 1, infection. Number 2, inflammatory diseases. So infection, inflammatory diseases. Number 3, so infection, inflammatory diseases. Number 3, neoplasms, malignancies. Number 4, miscellaneous, other. Miscellaneous, the word is other. There are other causes. So infection, inflammation, neoplasm, and miscellaneous, other. Right. Now, by looking back at your history and by asking certain specific questions also, now you're trying to narrow this down further. So let's start with infection. What are the important differentials to consider under that group? Infection, what are the sort of important things in the history that you need to ask for? Right? Mama history ekai, examination ekai dekama metendi kiyanna. Etore lazy, and then we can talk about it a little bit more. Right. So monowada api balanna. Right. Now, one of the most important causes of prolonged fever, infection, right, in a community-based patient is tuberculosis, number 1. In Sri Lanka, number 1 is tuberculosis. So write that down first, tuberculosis. Right, infection mein kiyanne tuberculosis. In tuberculosis, the key things in the history are that they usually get a low-grade nocturnal fever with night sweating. That is a typical story, right? Low-grade nocturnal fever with night sweating. They may or may not have respiratory symptoms. They will have respiratory symptoms, but it is not always the case. So they get a low-grade nocturnal fever with night sweating, may have respiratory symptoms. But remember, in tuberculosis, they have very significant loss of appetite and loss of weight. So you can't diagnose TB without weight loss. TB usually causes a lot of weight loss, right? That is very important. Okay, so that is a usual story with tuberculosis in the history. Now remember, because TB is endemic in Sri Lanka, they don't always have to have a contact history of tuberculosis, right? And the absence of a contact history does not exclude TB. But of course, mention if they have a very significant contact. For example, if they are a healthcare worker, or they have recently looked after a patient with tuberculosis, or one of their family members had TB. If there's a very strong link like that, do mention it. But the fact that there is no contact history doesn't exclude TB by any stretch of the imagination, right? So, eka passema nahinda epa, right? Now, examination findings in tuberculosis, again, you might find lymphadenopathy, right? Some respiratory findings like pleural effusions or apical findings, apical consolidation, because as you know, TB has a predilection to affect the upper lobes. They might have pleural effusions also. And they might have organomegaly, hepatosplenomegaly, which more disseminated tuberculosis, they will have hepatosplenomegaly. Right. So these are some of the things that you look for in the examination for tuberculosis. Right. Okay, fine. So those are the things. Right. So TB, hari, katandare, hari, infection, tuberculosis. Right. The next important thing you need to consider under infection, because infection, inflammatory, neoplasm, and miscellaneous. Hari. So infection is endocarditis. So next thing, number 2, write down endocarditis. And this is frequently the case. You get this in your long case. Right? Endocarditis, of course, they are at a higher risk of endocarditis in the history if they have some pre-existing cardiac problem, right? Valvular congenital heart disease. Especially if you're taking congenital heart disease, cyanotic congenital heart disease increases the risk. Or they have some sort of prosthetic material in the heart, either a valve or some other sort of prosthetic material. So they have valvular congenital heart disease. They have some prosthetic material in the heart, right? And that can cause predispose you to endocarditis. Of course, endocarditis can be triggered off by bacteremia, right? So dental procedures can generate bacteremia, but mostly if they are using intravenous drugs, right? Intravenous drugs, right? And the incidence of use of intravenous drugs in Sri Lanka is going up. So you will see patients who are abusing IV illicit drugs. So history of that is very important as well, right? And otherwise in the history, there's nothing much except for if they have very severe endocarditis, they might have features of heart failure on top of the prolonged fever. So that might be another clue to say, okay, there is something cardiac going on, right? Heart failure, right? examination in endocarditis, you might see the peripheral stigmata of endocarditis like clubbing, Janeway lesions, Osler's nodes, and obviously you'll find a murmur, right? And these murmurs are mostly regurgitant murmurs when you have valve problems. So endocarditis affecting the valves, they will have valve destruction. So they have regurgitant murmurs on examination. So endocarditis වල A findings ටික තමයි අපිට තියෙන්නේ. So popular cases for the exam when you have a prolonged fever patient coming, first thing is the clinical classification. So we've decided that the patient that Naveen presented has a community-based problem. And then you have the various subgroups: infection, inflammatory, malignancy, and miscellaneous. So under infection, endocarditis and tuberculosis are two of the very most important problems that you would consider as differentials always. Right. Now, apart from this, obviously, there are some other things also that you need to consider, right? And I will just give you a list and important things in the history and examination that you should focus on. Right. Another famous disease that presents with prolonged fever is typhoid, right? That's another important thing. And remember, typhoid, they may have GI symptoms. It usually starts with constipation and then diarrhea. But there'll be usually an epidemiological sort of a link, right? Either somebody in the family has got it, or there'll be a sort of outbreak of it, right? So, that epidemiology, it's through contaminated food and water that you get it. So there'll be some sort of epidemiological connection to your case, right? Examination, the only thing you might find is something like splenomegaly. Now, remember that typhoid does not cause fever beyond about 2 to 3 weeks. So, මාස ගානක් උන තියෙන මිනිස්සෙකුට typhoid කියන differential එක කියන්න එපා. Right? Sometimes you have patients with prolonged fever months and months. Typhoid is not a differential, right? Typhoid, the maximum you can get is about 3 weeks of fever, because either by that time they die or or you treat them, right? Then they improve, right? Whereas, typhoid can cause various perforation, ulcers, and various issues. So that's very important, right? So typhoid fever, right? Godak kal yanne ne, right? So endocarditis, TB, typhoid. The next one is typhus. Now, typhus is also a very famous cause of prolonged fever in our country. It usually presents with very, very high fever. In the history, they have very high fever, joint pains, right? And they have a lot of various types of skin rashes, right? Various types of skin rashes as well, right? That is a very typical sort of story, right? Skin rashes, amethanama rashes, These rashes can range from maculopapular rashes to vasculitic rashes, right? Vasculitic rashes, maculopapular rashes, right? And those days we used to say, okay, typhus හැදෙන්නේ කතරගම පැත්තේ ගියාම, or they go to Polonnaruwa, go into a jungle or something and get it. But remember, typhus can occur in urban communities also, so it is not confined to Calais, right? But of course, if they've been to a Calais recently, that might sort of increase your diagnostic sense. But Calais එකට යන්න ඕනේ නැහැ, කොළඹ හිටියට typhus හැදෙන්න පුළුවන්. හරි? But of course, the risk is higher in the scrub jungle regions and certain areas of Sri Lanka. Right. Examination, you find this very famous Eshka, which looks like a sort of cigarette burn mark, right? Eshka. Sorry. And they often have lymphadenopathy, right? So typhus, they usually have lymphadenopathy. Okay. So, infection යටතේ endocarditis, tuberculosis, typhoid, and typhus, right? Another important infection that has gone up in Sri Lanka quite recently is melioidosis, which presents a prolonged fever, 2 weeks, 3 weeks. Melioidosis. Now, if you remember your microbiology, they will have taught you that, and this is sort of Professor Inoka Korea's pet topic. She does a lot of research in it, and she would have definitely taught you melioidosis in your modules. And then she would have told that melioidosis, the organism, resides in the soil. So this is a certain group of people that get melioidosis. Most in people from agriculture-based communities or farmers, right? So melioidosis. And the typical story in melioidosis is they have abscesses. That is what happens in melioidosis. They get deep-seated abscesses, right? Everywhere. You can get abscesses anywhere. I have seen abscesses, melioidosis abscesses in the brain. I have seen them in the spleen, liver, everywhere, right? So, and parotid gland abscess, okay, abscesses. So they get deep-seated abscesses, right? Right. Okay, then harini. Of course, there are lots of other infections, right? But these are the important ones that you need to consider, right? Or agricultural communities, tava infection, brucellosis. It comes from cow's milk, unpasteurized cow's milk. The presentation is quite similar to tuberculosis, right? Quite similar to tuberculosis in certain ways. Hari. Infection, these top sort of 5 or 6 infections. Right. Right. Malaria, right? Sri Lanka doesn't have malaria anymore. So a travel history from Africa or India or somewhere where malaria is seen and prevalent can trigger you to think of malaria. Right. So several infections api kata kara, but the last one is probably most important. Remember that undiagnosed HIV can also present with PUO, undiagnosed HIV, right? And it's an important cause of PUO. So important that when I teach you the investigations, I will tell you all patients with PUO, prolonged fever, have to have a HIV test, right? Very important. So in your history, don't forget to ask for sexual promiscuity, multiple sexual partners, unsafe sexual behavior, sex without using protection, those sort of things are important to ask. Because you can't build up so much rapport during that very short period of time. Examine it. Examine right. So these are some of the important infections that cause prolonged fever and also PUO. Right. So endocarditis, tuberculosis, typhoid, typhus, melioidosis, brucellosis, yes, but not very important. And then HIV, malaria. Those are the important infections that you need to think of in a patient with prolonged fever or Pyrex or Untitled. Infection, there are 20-30 more infections, but these are the top ones, especially from an undergraduate exam point of view. Right. Any questions up to now? So I've given you a sort of stepwise clinical approach to PUO and prolonged fever. First, describe the fever nicely. Then try to establish the clinical category. Is it a community-based? Is it hospital-based? Is the patient diagnosed with some immunosuppressive illness in the past? Or is on immunosuppression? Right? Is it a hospital? Is it a travel history-based or travel-related thing? You need to classify. And then now you go on these main 4 groups: infection, inflammation, malignancy, and miscellaneous. And we have talked about infection. Any questions up to now? Mic on kalla, hand karuna kalla, if you have any questions. Right. So then infection, inflammatory. A big heading is inflammatory. Now, inflammatory includes various types of things, connective tissue disorders, vasculitis, and also granulomatous diseases. One of a granulomatous disease is sarcoidosis. But that is an example of a granulomatous disease. Right? So these are the various types of inflammatory disease. So connective tissue diseases, vasculitis, and granulomatous disease. Right. So the common unusual things are, if you take autoimmune diseases, connective tissue disease, SLE, right? Various types of vasculitis. So the SLE, you get this joint pain. In the history and the examination, you can see rashes, oral ulcers, the typical sort of mela rash, oral ulcers. Right. And the important thing about these connective tissue disorders or vasculitis or whatever it is, they involve multiple organ systems, right? Multiple organ systems, skin, heart, lungs, kidneys, multiple organ systems will be involved. So that is in that history and examination, you're looking for multi-systemic involvement, right? But for an undergraduate level, SLE වගේ එකක් තමයි නිතරම දුන්නොත් දෙන්නේ, and then you will have the very typical joint pain, skin rash, oral ulcer sort of story, right? But remember, all of these sort of inflammatory diseases have a multi-system involvement. Multiple systems are involved. Right. And they are usually joint, skin, plus other things. Joint, skin, plus other things. Right. Okay. Right. There is a particularly important connective tissue disease called adult onset Still's disease that presents with prolonged fever. And you might encounter this in the exam also. Right? So, adult onset Still's disease. You can put that because I have seen patients and you can get those patients for the exam. What they have is, again, usually quite a high fever, right? And they have joint pain and a rash, which is a transient rash, which is a transient maculopapular rash that comes on with the fever and then goes away, right? So the typical story is it comes on with the fever and then vanishes. It's a transient maculopapular rash coming on with the fever and then going away. That is a typical story. That is a special thing I would like to highlight under inflammatory disease. Right? In the examination also, you can see this rash, right? This transient, it's a maculopapular rash, right? Okay, and they have joint involvement also. That's adult onset Still's disease. So infection, inflammation, cover kara. Next, going to malignancies. Now, there are several types of malignancies that can present with PUO, and probably the most important of the lot is lymphoma. Right? Several malignancies, list එකක් කියන්න, but the most important one is lymphoma. Now, the history of lymphoma, again, causes a nocturnal fever, right? With, night sweats, loss of appetite, loss of weight, right? So nocturnal fever, night sweats, loss of weight, loss of. It's a typical story of a lymphoma presentation. And they also have, on examination, lymphadenopathy and hepatosplenomegaly. And that is a typical thing that you see, lymphadenopathy and hepatosplenomegaly. So of all the malignancies, lymphoma is probably one of the most important malignancies that you get causing prolonged fever and Pyrex of unknown origin. But of course, remember, there are other malignancies, and we can just write down a list of those malignancies like renal cell carcinoma and hepatocellular carcinoma. Right? So renal cell carcinoma and hepatocellular carcinoma. These also can cause prolonged fever, but lymphoma is by far one of the most important malignancies that cause prolonged fever. Okay. Then when it comes to the miscellaneous group, miscellaneous group drug-induced fever. So obviously in a patient with prolonged fever, taking a drug history is very important. Detailed drug history. And then of course, things like endocrine diseases like thyrotoxicosis can also cause prolonged fever. So those are some of the miscellaneous things that you need to think of, right? Miscellaneous things that you need to think of. Right. So this is sort of a simplified approach to a patient with prolonged fever, right? So first take the clinical category. Then within that clinical category, in this case, it is a community-based patient and a community-acquired scenario. There, then you subdivide into infection, inflammation, malignancy, and miscellaneous. Infections mang hayak hatak kiwa, most important ones. Then malignancy, inflammation. And infectional chutta liya ganna. Also remember that any localized deep abscesses anywhere can also cause PUO here, right? Localized deep abscesses anywhere, like, for example, discitis, prostatitis, dental abscesses. These are also cause of prolonged fever, right? Because they're hidden away from the external environment. So, infection, inflammation, neoplasm, and miscellaneous. Right. Any questions about that approach? Okay. The last thing I have to say in your history and examination is never ever forget to take a travel history, and you know the reasons for this. Never ever forget to take a detailed travel history, drug history, and if you have you need to attempt to take a sexual history. These are very important when it comes to a patient with prolonged fever. They are anyway important in any history, but in this particularly important, right? So what are the three things? Never ever forget to do take a travel history, a sexual history, and a drug history. And now you can realize why those are so important, right? Those are so important. Right. Okay. Right. Any questions? So that is your approach. Hari. Now, based on this, let's go back to Naveen's patient. And now we can see this patient has prolonged fever and the diagnosis is looking quite obvious to us. You can say the most likely diagnosis here. So the most likely diagnosis is infective endocarditis. Why the patient has prolonged fever, and also there is a history of a cardiac valvular problem which is awaiting intervention, and that tells us that this valvular problem is quite severe. So those two things put together, obviously the most likely diagnosis here is infective endocarditis. But sometimes it's not this obvious and you need to come up with a list. But here, this is quite obvious. This is quite obvious, right? So pre-existing cardiac valvular problem plus prolonged fever, your most likely diagnosis is infective endocarditis. So keeping that in mind, let's go to the examination, Naveen, and what did you find?
So on examination, he was normal build with a BMI of 21. He was afebrile, not pale or icteric. He had poor dental hygiene and had clubbing. However, he did not have any other peripheral stigmata of infective endocarditis. There was no lymphadenopathy. He had a BCG scar. There was no Martu scar. And he had an IV cannula on his right hand. And there was no ankle edema. However, he had a bilateral gynecomastia. On cardiovascular examination, he had a pulse rate of 64 beats per minute, which was high in volume, but it was not a collapsing pulse. It was regular, normal in character. There was no radial or radiofemoral delay. He had a blood pressure of 120/70. The JVP was not elevated. On precordial examination, he had a visible apex. The apex beat was in the 6th intercostal space, lateral to the mid-clavicle line. That's a deviated apex. It was thrusting in character, and there was a thrill over the apex. However, there was no left parasternal fever, any other particular heart sounds. He had on auscultation, he had a loud S1 and a soft S2 and a pansystolic murmur that was heard west at the apex with radiation to the axilla. On the respiratory examination, he had a respiratory rate of 24, with 24 breaths per minute, and he had normal vesicular breathing with the same intensity over all three zones. Other than that, the respiratory examination was normal. On abdominal examination, there was no tenderness or any palpable masses. There was no septosplenomegaly. And on neurological examination, there were no neurological focal neurological signs.
Okay, right. Thank you. Right. So can you summarize the whole case for us now, Naveen?
Yes. This 62-year-old male from Hatton presented with a low-grade intermittent fever for 2 weeks duration, which is more pronounced in the evenings and is associated with chills, night sweats, loss of appetite, and a generalized body weakness. He also complains of a productive cough for 1 week with no exertional dyspnea. He is a known patient with a cardiac valve disease since 1 year ago and is awaiting valve replacement surgery. He had no significant travel history, close contact history of TB, childhood cardiac problems, IV drug use, or high-risk sexual behavior. He is a known patient with hypertension and diabetes mellitus complicated with ischemic heart disease, stroke, and symptoms suggestive of neuropathy and nephropathy and neuropathy. And on examination, he was afebrile, not pale, had clubbing, but no other peripheral stigmata of infective endocarditis. He had a regular high-volume, non-collapsing pulse with a pulse rate of 64 and a grade 4 mitral regurgitation with a loud S1. There was no evidence of heart failure, hepatosplenomegaly, or focal neurological signs.
Hari. Okay. Now, let us imagine that you got this case for the exam. And now from this point onwards, let's just go through the discussion points. The මේ case එක අහන්න පුළුවන් දේවල්. ඉතින් මේ case එක විතරක් නෙවෙයි endocarditis මේවයි case එකක් කරන ඕනම වෙලාවක මේ ප්‍රශ්න තමයි අහන්නේ. Now, obviously, you will be asked to give you a most likely diagnosis, which you have all done. Even after history, we can sort of come to a most likely diagnosis. And the examination further solidifies that. Why? So examination, right, fine. The patient has clubbing and the physical signs consistent with a mitral regurgitation. The only thing that's slightly odd is the loud first start sound. Why do you think that is, Naveen? Why do you think the first start sound is loud? Now, because usually in mitral regurgitation, the first start sound should be soft. If there's obviously very, according to your presentation, it's a very significant mitral regurgitation. So there is a deviated apex, there's a thrusting apex, there's a pansystolic murmur, there's a thrill radiating to the axilla, all of beautiful physical signs of mitral regurgitation. This is what we discussed last week, right? Now we know that. Slightly unusual thing, loud S1. Why do you think that the patient is a loud S1?
Could there be a mixed valve disease?
Might be an underlying mitral stenosis also. Who knows? We don't know that we don't hear a murmur of mitral stenosis, but when possible. That is a possibility, but it's rather unusual to have a very loud S1 in such a severe mitral regurgitation. So please go and re-examine to see if that's accurate. But exam right? So this is just to check what your thought process is. Is there irregular pulse?
No, sir.
No, right. So that is a side thing that doesn't fit, but otherwise, and also remember when you have tachycardia, heart rate tachycardia, yeah, so I don't know why the S1 is loud. There might be an underlying mitral stenosis, which is likely given the fact that this guy is from Hatton, probably from a tea plantation. Where was he born? Hatton,
Hatton, yes, sir.
So probably is from a tea plantation sort of setting that we don't know.
Not sure.
Not sure. Now, why that's relevant is we know that things like rheumatic fever, rheumatic heart disease, very, very high in those communities. So might well have been this guy had rheumatic mitral valve disease, and the regurgitation is the more prominent thing now. But remember that, so people in these communities from tea plantations, Hatton, they are more likely to have chronic rheumatic heart disease. So thought process right? Okay, right, very good. Right. Now the next thing that we need to learn now is, right, how would you confirm the diagnosis now? So the exam, how would you confirm the diagnosis? Before we come to that, I will tell you firstly, in any patient with prolonged fever, what are the investigations to do? And then we'll talk about this patient. So in any patient with prolonged fever, what are the investigations to do? Right. In any patient with prolonged fever, you have to do a full blood count of obvious reasons and a blood film, essential, anivaryam karanna. And the blood film can be very useful to diagnose various things from cancer to other things. So yes, so full blood count, blood film, very important. Anivaryam karanna. You have to do a urine full report, right? And basic cultures, blood culture, urine culture, hemoglobin karanna, blood culture, urine culture. So full blood count, blood film, blood culture, urine full report, essential for everybody. Get a chest x-ray for everybody, because things like TB can be easily diagnosed in a chest x-ray. Simple investigation, chest x-ray, right? Chest x-ray. And then also do a HIV test, anivaryam karanna. So these are the sort of 5 or 6 important investigations that you do in a patient, any patient with prolonged fever, right? Anivaryam karanna. And then the subsequent investigation, so full blood count, blood film, urine FR, urine culture, blood culture, chest x-ray, HIV test, anivaryam karanna. And then the other subsequent investigations depend on what sort of differential diagnosis you have, right? So the subsequent investigations depend on what sort of differential diagnosis you have. Right. Okay, now coming back to this patient. Now this patient, we are thinking of endocarditis. Everything is strongly supporting that diagnosis. The fact that the patient has valvular heart disease in the past, coming with prolonged fever, has a very significant mitral regurgitation, is very likely that the patient has mitral valve endocarditis. So now let's turn, apart from the basic investigations, how would you confirm the diagnosis of endocarditis? ඒ ප්‍රශ්නේ අහුවොත් මෙහෙම තමයි කියන්නේ. Right. Infective endocarditis, as all of you know, and they would have taught you this in your lectures, in your modules, that endocarditis, the diagnosis is based on a diagnostic criteria. Diagnostic criteria. And that is called the modified Duke's criteria. Now, this modified Duke's criteria has major criteria, minor criteria. But remember, the major criteria are around microbiological confirmation of the diagnosis, right? Microbiological confirmation of the diagnosis, and also echocardiographic confirmation of the diagnosis. So those are the two key things, key elements. Then, ඔගොල්ලෝ exam එකේ Duke's criteria කටපාඩමින් කියන්න ඕනේ නැහැ. An examiner will ask that is absolutely crazy because I don't think even the examiner can remember that. But you should know the principles behind Duke's criteria, saying that in order to make a diagnosis of endocarditis, you should have blood culture criteria, right? And echocardiographic criteria. So obviously you will request an echocardiogram and also take blood cultures, right? And it's better if you can take 3 sets of blood cultures, right? 3 sets of blood cultures. 3 sets of blood cultures. And from different sites if possible, right? 3 sets of blood culture from different sites if possible. ලංකාවේ anaerobic culture, fungal culture නෑ, but 2 bottles per site ගන්න පුළුවන් නම් හොඳයි, right? They usually recommend you to have about half an hour gap between it, but එහෙම අත්‍යවශ්‍ය නෑ. Right. Okay. So blood cultures යවන්න and also echocardiographic criteria. Get a transthoracic echo, which is the first thing you need to do. Sometimes you might request for a transesophageal echo when the diagnosis, you can't see anything on the transthoracic, but remember the first thing you do is a transthoracic echocardiogram. Remember that there are various causes of culture negative endocarditis, right? Now, even though I've said that the 2 major criteria are culture, blood culture usually, and then echocardiogram, remember there are certain causes of culture negative endocarditis. The cultures can be negative, right? Culture negative endocarditis, the commonest cause of culture negative endocarditis is actually prior antibiotic use. And this is a very common problem in Sri Lanka where නිකන් උණ හැදිලා GP ගාවට ගියම antibiotic දෙන්න, right? Which is it's a horrible practice. And also people can just go to the pharmacy and get antibiotics, right? So නිකන් උණ හැදිච්ච ගමන් people start taking antibiotics. So culture negative endocarditis can be due to prior antibiotic use. And also there are various organisms that are culture negative, right? In your theory, they would have taught you about HASEC group of organisms and things, fellows like Coxiella and Brucella, which are culture negative, right? Which are culture negative, right? Hari. So, culture negative organism. So, exam එකේ ඔන්න ඔය ප්‍රශ්න ටික හොඳට අහනවා. ඉතින් what are the basic investigations which I have gone through already? And for endocarditis, you're trying to fulfill or complete a modified Duke's criteria, which is echocardiographic criteria and also has blood culture or microbiological criteria. But remember, there are certain causes of culture negative endocarditis which you have to investigate different, like Coxiella, Brucella, etc. Right? And all this HASEC group of organisms. Also remember, rarely these things like fungal endocarditis can also have culture negative endocarditis. Not very common, but can happen. Right. So, Naveen, now can you tell us the investigation findings then of your patient? So start with the full blood count, blood film. Basic investigation, CRP, CRP-SR, then urine, blood culture. So exam also, you will have this sort of to and fro with the examiner. When you say an investigation, the examiner will give you all the investigation reports and you're supposed to go through them and interpret them on the spot. Right? Yes. But he, of course, now he knows the investigation, so he will, yeah.
The initial investigations, full blood count, WBC was 12, and neutrophil was about 60.9.
Okay, so that tells us there's a bacterial infection. Okay, good.
Other than that, his hemoglobin was 11, sir, and had a platelet of 370. And his
hemoglobin is slightly low, ne, Ravi?
Yes.
Okay. So now, Naveen, what are the possibilities for a low hemoglobin in this person? Why do you think the person is anemic? What are the possibilities?
So, from the place that he comes, because he's from Hatton, so he's
So obviously nutritional deficiency, worm infestation, very common in these areas. That might be a pre-existing anemia. Very good. What else? Can the anemia be related to endocarditis itself in any way?
Hemolysis in endocarditis?
Yes. So endocarditis, there can be hemolysis, especially when there are big vegetations. They can get hemolysis because it's a mechanical vegetation and the blood cells burst apart. As they go through the valve, there's a big gediya wage, it hits it and breaks. So they can have a mechanical hemolysis also, which can cause anemia. Okay, that's a side question, but and also remember that if there is inflammation going on for a long time, they can get sort of like an anemia of chronic disease also. Especially if they've had the fever for a long time, maybe 3 weeks, 4 weeks, they can get that also. Good. So wage ප්‍රශ්න නිකන් මැදට පැනලා අහන්න පුළුවන්. හරි? Okay, right. That's right. Continue.
So blood picture was done, so it showed mild rular formation with neutrophil leukocytosis and
Okay.
such of a bacterial infection with toxic changes.
හරි. මේවා ලියාගනින්න විතර උන් ටික. මොකද මේවා තමයි අන්තිමට බලන්නේ මේ cases ටික. Yes.
The inflammatory markers, CRP was initially 58.8. Now it has gone down, so but initially on presentation was 58.
Right. Okay. Then yes.
ESR was 27.
Okay.
And blood culture, 2 blood cultures were positive for Streptococcus constellatus.
මොකක්?
Streptococcus constellatus.
Constellatus. What is that? A group B streptococcus?
It's a variance group Streptococcus.
Variance group. So there are lots of 50ක් විතර තියෙන එක ජාති මට මතක නැහැ. But that's okay. Yeah.
HIV testing was not done, sir.
Okay.
They had done the TB screenings for sputum for TB and AFP.
That probably because of this cough business. You said there was a cough for a week, so it's not a completely stupid thing to look for TB also, but there is obvious diagnosis which is underneath. Okay.
So,
right. So that's very useful. We have got a basic set of investigation. Chest X-ray, I assume, was okay.
Chest X-ray showed right-sided highlight shadows, but then they were suspecting some ring shadows and bronchiectasis, but then later on they didn't.
Okay. Fine. Okay. Right. So now we have had some sort of basic investigations. Culture is positive. Now that's important, right? හැම වෙලේම culture is positive වෙන්නේ නැහැ. විභාගයේදී අහන common ප්‍රශ්නය තමයි culture negative endocarditis වලට හේතුව culture negativity in a patient with a endocarditis diagnosis. One of the common causes, as I told you, is a previous antibiotic use. Right. Hari. Okay, fine. Now that's all good. Now I want you to read හැමදේම උගන්වන්නේ නැහැ කියලා කිව්වනේ. I want you to read Duke's criteria, right, and see what is the sort of culture positive criteria කියවන්නේ. It's important. අදම මේවා කියව ගන්න. Small things මම homework වලට දෙන්න. අනිත් ගොඩක් දේවල් උගන්වනවා. එකක් දෙකක් පුවා උගන්වන්නේ නැහැ. මොකද ඕවා අපිටවත් මතක නැහැ. භාගයට culture criteria මතක තියාගන්න ඕනෙත් නැහැ. But you need to read them at least once. Right? Hari. Okay. Just read the modified Duke's criteria today. Major criteria we have already discussed, the principles. Read the minor criteria and see what qualifies as positive culture. කියන එක ඒකේ. Hari. Okay. This does, by the way, but you need to know what qualifies as a positive culture. Okay, fine. Now, what is the next one? Echo. Now, remember, obviously, you'll do an echocardiogram. In an echo, you're looking for vegetations. Sometimes they are so obvious you can see them as oscillating masses. Echo, okay, you will see oscillating masses. These are the vegetations. And also you will see new valvular regurgitation, new or worsening valvular regurgitation. Right. So Naveen, what was there in the echo? Naveen, your mic is off.
So I didn't hear the last question, so I got
Echo. What was there in the echo?
Yes, they saw severe MR, ruptured cord in the anterior mitral valve leaflet, and there was a calcified nodule seen in the anterior mitral valve leaflet tip. So
Hmm.
they think it's most likely to be calcified nodule of a ruptured cord, but there
Okay.
were no vegetations at the scene.
Hmm. Right. So they didn't see a vegetation. This is not uncommon. So if you do now, then kita then another prasnak ahana. Right. So your clinical history is quite suggestive. There is a patient with a valvular problem in the past. There is prolonged fever. Examination, there is a bloody murmur. There is clubbing. So we are thinking of endocarditis. Blood culture is positive, but the echo is negative. Then malalabbai. Echo is negative. Now, are you going to exclude endocarditis? No, you're not. You're going to do a transesophageal echo, which is more sensitive and specific to pick up vegetations. So your transthoracic echo might miss it, but your diagnosis is still quite possibly endocarditis. And then now you're going to do a transesophageal echo, which is more sensitive and specific. More sensitive and more specific to diagnose vegetation. So, I remember you saying it is not done yet.
Yes, because its CT value in the PCR was still less than 30.
COVID nisa. Okay. Right. Okay. Right. So, but that's fine. Okay. So this is how you establish a diagnosis of infective endocarditis. Right? So using modified criteria, blood culture criteria, and echocardiographic criteria. Right. Transthoracic echo is most often sufficient, but sometimes you need the transesophageal echo if the transthoracic is negative. තව පොඩ්ඩක් ලියා ගන්න සමහර මේ අහනවා transesophageal echo is also better at detecting endocarditis in prosthetic valves කියලා ලියා ගන්න. So it's better to detect endocarditis in prosthetic valves. Endocarditis, but ලංකාවේ ඒවා කරන්නේ නැහැ. Right. Okay, fine. Good. Right, moving on. Now, of course, at the exam, then most of the time is now finished. By the time you come to this stage, we will ask you a few things about the management of endocarditis. So how would you manage a suspected patient with endocarditis? Right. So, number one, obviously, antibiotic therapy. Antibiotic therapy. And the main principle here is that you use intravenous antibiotics, right? That is because you want to get the drug into a higher concentration into the valve and the vegetation. That is why you're giving high dose of, not a high dose, but you're giving intravenous antibiotics. Now, what antibiotic you use is empirical, right? Initially, until you get the results of the culture. So you use empirical antibiotics until you take the cultures and get the sensitivity, right, of the cultures. So what was the antibiotic that was used in this patient first, and then what is the patient on now?
So, he was started on gentamicin and C-penicillin, sir. And
Yes.
he's still currently on those antibiotics, sir.
Okay. So yes, so in Sri Lanka, the common empirical antibiotics we use for this sort of patient is C-penicillin and gentamicin. Now remember, endocarditis can also occur in various other settings like prosthetic valve endocarditis, sarcomeka. එතකොට antibiotic වෙනස් වෙනවා, right? That is a different story. When you have endocarditis or prosthetic valve, the antibiotics are different. But in this sort of patient, community-based patient with a native valve in situ, the antibiotics we use are C-penicillin, gentamicin usually. Right? But then the sensitivity, I think, you will have the sensitivity pattern from the blood cultures, no? Naveen?
Yes, sir.
So why are we still on both of those? Or is there because they're synergistic? But what is it sensitive to penicillin, this organism?
I think I saw the sensitivities.
Brother?
I think I missed the sensitivities.
That's okay. Just go and look at the ticket and see sensitivities. Right. So yes, so your treatment principles are: number one, you're going to treat the patient with intravenous antibiotics, and usually for a long duration, minimum 2 weeks. Some go up to 4 weeks, or sometimes more. right? So minimum 2 weeks, and you treat with antibiotics. Harini? Okay. That is one important principle of treatment, right? Second important principle of treatment is not always, but some people require surgical management. Some people require surgical management, especially if they have locally spreading infection in the heart. So these are the indications for surgical management. If they have locally spreading infection in the heart, that is one indication. If they have very severe valve dysfunction leading to heart failure, sometimes people have locally spreading infection, they call valve ring abscesses, valve abscesses, or they have very severe valvular dysfunction leading to severe valve dysfunction and heart failure, or they have big massive vegetations which embolize, right? So they have large vegetations which embolize. That also will be an indication for surgery. Surgery for endocarditis, right? But these are sort of the indications, right? Right. So those are the basic two things that we do in endocarditis management, right? So you give the patient antibiotics, and in certain very selected groups of people, we use surgical management, right? Right. Right. A surgical management, fungal endocarditis also surgical management. Fungal endo, very rare and very difficult to treat. Right. Now, other possible questions they might ask you about is about gentamicin. So I want all of you to go back to your pharmacology notes and read a little bit about gentamicin, side effects. Because one of the most important things that you need to worry about when you're giving things like gentamicin for endocarditis is nephrotoxicity. Hari. Okay. Right. Now, the last thing you need to know is, as a house officer, when you're managing an endocarditis patient, what do you need to do, right? Or monitoring. The exam, right? As a house officer, how do you do monitoring of your patient, right? So in your monitoring, there are certain things you do, right? And I will tell you the list and why you do them. Why you do them. Number one, daily clinical examination. Very important. Murmur. Clinically examine the murmur. Because if the murmur is getting worse, that means things are going south or deteriorating. So daily murmur examination, that is very important. Daily murmur examination. And you look at the intensity of the murmur, seeing it's getting very right? Daily murmur examination. Important. Then look at the patient's, assess the patient's response to treatment, right? The best way to do this is fever chart and inflammatory indices like white count, CRP වගේ දේවල්. ඒක දවස් 3න් 4න් පාරකට වගේ repeat කරන්න ඒවා ටික. So fever chart and then inflammatory markers to monitor the progress of the patient on antibiotics. So are the antibiotics working, in other words? Okay. So you do a daily clinical examination looking for the intensity of the murmur. The next thing you do is you monitor the patient's response to antibiotics by looking at the fever chart, looking through the investigation results like the white count and the CRP. Then the next thing to do is look out for complications, right? Complications of endocarditis. So complication of endocarditis can be local or embolic problems. So you do, again, daily clinical assessment will help you to look for these problems. If the patient has aortic valve endocarditis, do regular ECGs. That is a very easy way of seeing if there is a local problem. So if you have an aortic valve endocarditis patient, it's very important to regular ECGs. When the infection spreads around the aortic valve, it starts involving the AV node, which is very close to the aortic valve. When the infection spreads around the aortic valve, it starts infiltrating into the AV node. and that causes heart blocks. And ECG එක පේනවා පටස් කාලා. Right? අද කරපු ECG එක හෙට එක වෙනස් heart block ඇවිල්ලා තියෙනවා. So then you know there's something nasty going on. Right? So then බලන්න අපි look at the intensity of the murmur, monitor the fever and the inflammatory markers for response to antibiotics, then look for local and more distant complications. So local complications, one of the easiest things to do is ECG if you have aortic valve disease. Distant complications can be embolic or you can get immune phenomena like glomerulonephritis, again, immune phenomena, like glomerulonephritis. So keep an eye out for these problems. So as a house officer, these are the main things that you need to do when you're treating a patient with endocarditis. Monitor the murmur intensity, severity of the murmur, look for complications, and also look for the response of the patient to your treatment. That is your main thing as a house officer. That is it. Okay, that is it. So I'm just going to, please think of questions that you would like to ask me, but I'm just going to summarize the class that we did today. So today, and think of questions that you want to ask. So we discussed a 62-year-old patient with fever going on for 2 weeks, and then also had an existing cardiac valvular disease. Examination, we found a very severe mitral regurgitation and clubbing. So the first thing I told you was, fine, how would you approach a patient with prolonged fever or pyrexia of unknown origin? PU has a very slightly different definition, and you have to read that definition. Right? It has changed over time as well. Right. So that's the first thing. I taught you the approach. What are the things? What are the differential? How do you approach? So describing the fever, describing the clinical category that the patient falls into, and within each clinical category, what are the other subgroups that you need to think of: infection, inflammatory, neoplasm, and miscellaneous. And we discussed the important differentials, the history examination. Right. Then we said that this was most likely endocarditis, and I went through with you any patient with prolonged fever, what are the investigations to do, right? Any patient with investigations with endocarditis, what are the things to do? And then specifically, how to diagnose endocarditis using Duke's criteria, what are the things that you need to do? We listened to all the things I told you about echoes, various uses of transthoracic, transesophageal echoes, what to look for in the echoes, the cause of culture negative endocarditis, all these are related to the diagnosis. And then the main two principles of managing endocarditis are antibiotic therapy and surgery when needed. And I gave you some important indications for surgery in endocarditis, right? And then finally, as a house officer, what do you need to do when you're managing a patient with endocarditis? But all patients with endocarditis should have prophylaxis, usually drug with amoxicillin, before undergoing invasive, usually dental procedures. Right. So, any questions?
Excuse me, sir. If the transesophageal echo is more sensitive and specific, why don't we do it without doing the transthoracic echo?
Why? Because it is an invasive procedure. It's an invasive procedure, and it needs special training and a trained person to do it. Echo කරන්න පුළුවන් ඉම්මූලටත් echo කරනවා, transesophageal usually needs a little bit more training to do. So all of those factors, and if you can diagnose something by transthoracic echo, you don't have to do that. No, transesophageal කරන්න අවශ්‍ය නැහැ. But transesophageal gives you a more detailed look at the heart, and also it also gives you in special instances like prosthetic valve endocarditis, the pickup rate is better. But it is invasive and requires more specialist input.
Sir, we were presenting the history, sir. So, like you said, so initially you described the fever, sir, and then you classified into one of those classifications, sir. So, in that classification, do we have to say that at the onset itself that he does not have any recent hospital admissions prior to the onset of fever and all those things?
No, from what you presented, it will be apparent. පැහැදිලිව කාගේ නැග පෙන්නන් ඉන්නේ යකෝ. හරි. කැමරා රෙකෝඩ් බලාගෙන බල එක එක පේන්න ගන්නවා. හරි. Okay. Fine. Right. So when at the end of your presentation becomes quite obvious. So you don't have to categorically state that. At the end of your examination, it will be obvious. Examination presentation, it will be obvious. So you don't have to really worry about it too much. So how long will it take to see improvement? That's a very good question, hey Shani. Usually, if you start appropriate antibiotics, within 48 to 72 hours, you should begin to see some sort of improvement. 48 to 72 hours, you will begin to see some sort of improvement. You don't have to apologize. Whatever, you don't. Okay. Unless, of course, you want to show your body to somebody in the group.
Excuse me, sir. When we do dental procedures, what are the antibiotics we can use for prophylaxis?
Amoxicillin. That's about before the procedure, about an hour before the procedure, amoxicillin. That is a recommended thing. And for homework, also find out, now I told you, if you have had an endocarditis history, you have to get prophylaxis. There are certain other indications for antibiotic prophylaxis for endocarditis. Heart murmur and prophylaxis then there are indications for prophylaxis. So but one of those indications is previous history of endocarditis undergoing dental procedure, definitely yes, right? But there are other situations.
Sir, may then 2 weeks fever එකදී මේ clubbing තියෙන්න පුළුවන්ද?
පුළුවන්. එහෙම ලොකු problem එකක් නෑ. Right. How is a patient with endocarditis follow-up discharge? Usually, it depends on how bad the endocarditis was. හොඳටම valvular problem එකක් තියෙන මිනිස්සෙකුගේ, then you need to do echo at least about 3 to 6 months afterward echo එකක් කරනවා. හරි? And then sometimes කොච්චර antibiotic දුන්නත් the thing is so severe, they need subsequent valve replacement. මාස ගානකට පස්සේ once everything settled, we can replace the valve if it's very, the damage is very severe now. Okay, I mean then that's fine. Eh? Tomorrow we will do what? List එකේ